probably do that in your clinicals or see those monofilament testing. That's what you're doing to test for sensation on the patient's foot. And here's a tip. Don't ask, hey, can you feel that? That's not the way this works. Usually you take the patient's hand, you show them what it's gonna be like on their hand, and you say to them, please let me know when you feel this. And you don't say anything else as you're testing it, okay? And they're gonna be able to tell you. You'll be surprised at how many of them have loss of sensation in their feet. So I'm gonna skip over that slide, and we're gonna talk about non-modifiable risk and modifiable risk. Okay, so in our minds, including mine and clinicians that I see everywhere, almost always when we see neuropathy, we think diabetes. But I want y'all to realize that not every patient who has neuropathy has diabetes. So when you see these, you should ask yourself, is this a diabetic patient? If it's not, start looking for other factors that can cause the neuropathy. Because you will have these ulcers that occur like this for anybody that has neuropathy. It's not the diabetes, it's just that diabetes is the most common cause. So the reason I bring that up is because commonly these get called diabetic foot ulcers. They are not diabetic foot ulcers. They are neuropathic ulcers. The neuropathy is the cause of that, not the diabetes. Just so happens that the diabetes causes the neuropathy. So having said that, when somebody says, oh, my patient has a diabetic ulcer on their leg, the answer to that is no, they don't. Because there is no such thing as a diabetic ulcer on their leg, okay? Neuropathic ulcers occur exclusively on the feet, on the sides of the toes, the plantar surface of the foot. We're going to talk about that in just a second. If they have an ulcer on their leg somewhere, the cause is something else. And you're going to have to investigate that to figure out why, okay? So you'll see that often. People say, oh, they have diabetic ulcers on their legs. They do not. There's another cause of that. Okay. So, if you talk about the things that can cause you to have neuropathy, that's going to be things like exposure to heavy metals and also disease processes, which are these. Hansen's disease. Anybody know what that is? That's leprosy. So leprosy is one of the causes that you can get. Those ulcers on them are from neuropathy. Raynaud's, pernicious anemia, chemotherapy, just advanced age. You will see these all cause neuropathy in your patients. Okay, so what happens is they get a loss of protective sensation. They may have a history of foot ulcer that makes them at higher risk. They have rigid foot deformity, poorly controlled diabetes, and having diabetes for greater than 10 years. So you had asked me earlier about, your foot being built in such a way that you just don't get an ulcer. Well, your foot and my foot is generally that way. But when you have diabetes, it changes the way your foot is structured, if you will. There's changes that happen to your toes, to the the muscles and the ligaments and all of that. All of that changes, okay? And your toes start to kind of curl under a little bit, and that's why you'll see ulcers on the toe tips that happen. And then it also changes when you lose that loss of sensation, how your foot plants, and you'll get a slapping motion when you walk. That will cause repetitive trauma on those foot pads. That's why you will see very commonly patients have ulcers on their metatarsal heads. The first and second are notoriously common for that because of the way they plant their foot. And then one other thing happens with this, if they get what's called an autonomic neuropathy, whereas when you or I have foot sweat, you're hot, your foot sweats, right? You're cold, you get vasoconstriction, and you have cold feet. Those people don't have that with neuropathy. They have no change in their blood flow to their feet. It's all one thing because the vasoconstriction and vasodilation doesn't happen. It affects the sweat glands, it affects all of that. That's why they get fissuring and dry feet, and they will also get demineralization of the bone as a result of that, and they will have a collapse of the arch and what's called a Charcot's foot. Is anybody familiar with that? Or that rocker bottom foot that occurs because their bones just demineralize and just collapse there. So you'll see all those deformities happening. So I have some pictures for you as we go through and talk about these. These patients are also at increase for osteomyelitis. That occurs as well. So here's that monofilament testing. I showed you guys this is the Sims 1 5.07 monofilament. and you see it, and then whatever test you're doing, wherever facility you're at, you will have a, form that tells you the spots to check on their feet for sensation, and it should bend like that. So here's those examples of deformities that change. You get these hammer toes and all this mess. See these nice deformities. And so there you see already this patient talking about changes. You see right here how the calluses are starting to form. And when those calluses fail, they'll develop an ulcer. So like this, they'll start to get dark underneath, and when you see that darkness, that's a heralding sign that you have blood underneath and you have an ulcer there likely. And there's those toes that I was talking about that change. And there's that rocker bottom foot. You see how that foot doesn't have a arch, it just bulges out? That's because the bones are collapsed there. So, ironically enough, they have normal skin tone. They usually have palpable pedal pulses. But you'll notice skin changes, like the fissuring that they happen, they'll build callus like nobody's business. The wound margins are typically well defined. Exudate can be variables, and their reflexes are diminished, obviously, because of the neuropathy. So they scale these, and you guys don't have to remember any of this. I was just giving you some examples, so I'll show you. They classify these based on how far they go. So like, at the top, you have really no open lesions, but there can be presence of this all the way to extensive gangrene or bone infection. And they give them a grade based on that. That's what they, it's not really a stage, it's more grades that they've come up with for how extensive and what's involved with these. So it's hard to see in this picture, but this occurred due to a needle left in the patient's shoe. They stepped on it and just keep walking on it. So you'll see these patients. I know it's hard for you to imagine. I mean, it is maybe not for you, but for me, it's very hard to imagine because I can't walk across grass. I mean, if I walk across grass, my feet think they're dying. It's like, oh my gosh, how does anybody do that? But these patients, they literally cannot feel. So they will have something in their foot and not know it for weeks at a time if they're not looking at their foot for daily inspections. I mean, I had a neighbor lady that I took care of that caught her foot on fire, burning leaves in the yard. Her foot was burning. She had no idea. She couldn't feel it. So while that seems, to me, that seems so weird. It's like, how can you not feel that? I can feel the littlest thing, but they can't. So just keep that in mind when you're looking at this. It's very important that if you're taking care of diabetic patients, that you look at the bottoms of their feet and inspect that daily. So here's another one. Again, you see on the metatarsal head, and the callus has been debrided off of there. So you all see the common theme, right? Where are these located? They're on the bottoms of their feet, right? And you see that they're almost circular with calluses over and over. That's what you're going to see with these patients. Look on the toes and metatarsal heads. It's where you're going to most commonly see them. Okay? You may see them on the heels, but less often. More often on the heels, you're going to see pressure ulcers than neuropathic ulcers. And when you see the middle of the foot, you're just going to know that that's a Charcot's deformity. See how their foot bulges out. So when you talk, we're going to talk just a second about offloading these patients. I'm going to show you some pictures. When you offload a patient who has on the metatarsal head, you can use just a shoe with inserts, and I'll show you a picture of that in just a second. When you offload this patient, this has got to be a boot, and it's a brace that braces the entire foot. Because when they walk, the bone is just going crunch, crunch, crunch. Okay, there's nothing there. And when you look at it, I think I even have x-rays to show you, there's just nothing there. So you'll see that there's significant changes that happen. Okay, so, and this is a debridement of that, so you can kind of see how deep these go. Again, common theme. These have got all calluses, right? Bottom of the foot. You're going to see it over and over again for these patients. On the toes. Okay. So, and they may get deep enough that you guys, can you all see the tendon there?
Yeah.
That you have exposed tendon. So at the point that you have exposed tendon or bones, you need to be aware of that. You probably have osteomyelitis. You have a bone infection. And yes, that patient has no toes anymore. So here's, this deformity will also sometimes do that. The Charcot's vertebral bulge out there. Okay. So can you guys see how their foot is totally changed and how it's a different, look here. You see how the bone is gone? And this is the ulcer. And see down here? Where this is good bone up here, this is not. And here's the ulcer here. And there's the ulcer there. So this patient, just so y'all know, has osteomyelitis. Can you see how the bone is like gone there? Or changed, fragmented? So when they're doing these, that's how they're gonna see it. That's gonna be their, okay, they got osteo. And so they'll have to go in and debride that.
At what point do they make the decision to amputate?
Okay, so very much, we try for limb salvage. And sometimes, especially in your diabetic patients, if they don't have gangrene and we can manage it, we will symptom manage even chronic osteo, meaning we will leave their limb. And that's because the 5-year rate after amputation for morbidity and mortality is very high, meaning you die within 5 years. However, a piece of that goes along with perfusion. And we'll talk about this in a second with arterial wounds, because you can get an amputation. We amputate diabetic foots. We also amputate arterial or lack of blood flow to the limb. And it really depends on, you know, at what point you have gangrene and how far advanced that is. But what I want y'all to understand is, while that looks like it would be easy peasy and you just, okay, you think, okay, well, let's just take off the toe. That's not the way it works. So if you don't have good flow, and even though you have an ulcer on your toe and your toe's black, they're not gonna just cut it mid-foot and remove that toe. They're gonna do a perfusion study. They're gonna find out at what level you have the ability to heal. So I've seen patients with toe ulcers that end up with an above the knee amputation, because that's the level at which they can heal once I start cutting on them. Does that make sense? So it becomes a little tricky when you're looking at how you're gonna take, you know, do an amputation. But we try at all costs to do limb salvage because of the morbidity and the mortality. So you're looking at, is the infection overwhelming? Is the perfusion so poor? That's usually the indicator, is you have such poor perfusion that you just don't have the ability to heal, and you're gonna be overtaken by gangrene or infectious process. Does that make sense?
Yeah.
So you're gonna obviously eliminate trauma with these patients and offload them. We're gonna have hemoglobin A1C under control. You usually want them under 6 if at all possible. At the point that you go above 180 on your blood sugars, you stop with macrophage function. And if y'all know, macrophages are your white blood cells that come in and take care of infection. That's why the infection risk is so high for these patients with elevated blood sugars, because their immune system doesn't work properly. And it slows their healing, and it slows everything, because remember we talked about the importance of a good immune system and inflammation to happen, right, at the beginning. These patients are behind the 8 ball when they have poorly controlled blood sugars. Okay, so they have to be compliant with offloading. You have to consider their deformities. You also have to consider gait balance. So the standard of care, the highest standard, gold standard, if you will, for treating a patient with a neuropathic ulcer is to do what's called a total contact cast. Anybody familiar with that? So basically what you do is you use a cast like you would for a brake, a hard cast that's casted on their leg to create offloading. Well, y'all can imagine what that does to the weight for somebody who's 80 years old and has poor balance to begin with. You know, it can cause them to fall and break hips. So you have to consider that and weigh that against whether a total contact cast is appropriate. And it's also going to change their balance and change their feet, so they're going to have some muscle aches and deformities that can occur because it changes how they walk, as well as shoes. And I'm going to show you guys for a second that you all have to consider. So here, have y'all ever seen half shoes? These right here. Have you seen these? Anybody seen those? So have you ever tried to walk in one of those? So when you can't touch your toe down, when you walk, imagine if you can't touch your toe down, what that does to your leg and how these people walk. So then what that does is for a long period of time, as therapists, y'all know, what does that do to your muscles? You get shortened muscles and it changes that, right? So you have to be aware of that. The same thing happens when you can't touch your heel down and you're walking on your toe all the time. So, we use half shoes to offload them, but there is a trade-off and there's some problems that can occur with that. So in my facility, we use this at the top, which is called a Pegasus. And I had those, but again, with COVID, I didn't bring those. I have an example of those. But it's an insole. Can you see that? And it's about this thick. And what you do is you pull the peg out where their ulcer is. And then it goes in the shoe. So when they walk, there's a hollow space in the insole that's offloading that. Does that make sense? That does not change their gait. And that's why we do that. So the same thing with this shoe. Can you all see how this is an insole that creates a weightlessness where it's cut out? So it doesn't create pressure on that point, so it changes them. So this is a patient that used this half shoe. You can see there, and it does, you know, you get offloading, but obviously she's got a walker because you can't walk. And then here's a picture of a total contact cast.
Does it not cause issues with like where it is being like that pressure that's, you know?
A total contact
Yeah.
cast? It does, well, it can if you don't cast it right. So just like if you do, like, okay, let's say you cast somebody that has a break. If the cast is wrong, it can cause issues, right? It can cause pressure ulcers and other things in other areas. So they have to pad that and really be careful when they're doing it to make sure that they're not going to do that. If that makes sense. But yes, you can cause issues if you're not careful and you don't know what you're doing. So for me, I don't have experience in total contact cast to do the actual casting. That's usually a podiatrist that does that. I would never do that. I typically put patients, because of my patient population, in some sort of offloading shoe. And so here's an example of that. So I want to show you. This is the shoe they get, which is just basically a surgical shoe with this is the insole with the peg. And you can see the difference. So in the red is where their ulcer is. Y'all see that? Because that's the highest pressure point when they took a step. Now look at the bottom when we put the peg in. See how the pressure has gone from that area? So it creates weightlessness for the ulcer so it can heal. Okay, so, and here's a patient with diabetic shoes. So in my patient population, they're better now than they were. But one of the most common complaints I get is that they're ugly. Both that and compression socks, they're both ugly, and I'm not wearing those to church. Instead, I'm gonna wear my pointy-toed shoes that don't fit my feet. And, y'all can see like that, right there, you see pushing that foot into that shoe. And that's what happens when you do that. So you have to tell patients to be very careful. So there's this trick you do where you take their foot and you put it on a piece of paper and you draw around it and then you set the shoe on top of it. And if their foot extends out past the shoe, it's probably not the most appropriate shoe for them to wear, right? Now try telling an 80-year-old that's going to church that and see how that applies. So that's another big thing with these diabetic patients is appropriate footwear, foot care, and that includes nail care. So, you know, you don't let it get like this, and you laugh and you see this, but I swear to you guys, I see more of this than you can imagine. Because, you know, when you're 90 and nobody comes to see you and you can't bend down and clip your toenails, you know, who's gonna do that for you? Plus, they're sticking in yellow to start with, it becomes a big deal. So, you know, we try to get them to the podiatrist to take care of these things. This is that fissuring and stuff, and so, you know, you try to get them to moisturize because their feet are really dry and they get this hyperkeratosis and all this stuff that creates these problems. So like this part is nail, like this and this, but this is just dry skin, you know, that's fissured that you try to take care of. And this skin, you know, you wash your feet, put moisturizer on it. That takes care of that problem, right? But if you can't bend down, you know, think about it. I mean, you have patients that really, they cannot get to it. So you have to really, a foot care is a big part of it. So anybody have questions about diabetic ulcers? So what do? We offload them, right? Control their blood sugar, good foot care. And how do we know that they're a neuropathic or a diabetic ulcer, as we call them? Where are they at? On your feet. Usually on what part of your feet?
The ground.
The bottom, plantar surface, right. Okay. So next we're gonna talk about arterial ulcers, and these are often called, it's called Lee's lower extremity arterial disease. So I need y'all to go back to anatomy and physiology, because I still have nurses that I deal with that get confused about this. Okay, so really quickly when we talk about blood flow to our heart, our arteries carry blood to the tissues, right? So when we talk about perfusion, that's what we're talking about. Arteries carrying oxygen to our feet, to our hands, right? When we talk about venous flow, which we're going to talk about in a second, we're talking about veins carrying blood back to your heart, right? It is not oxygenated blood. We're getting rid of waste that way, right? So when we talk about these, we're talking about two different disease processes. So for the purposes of this next discussion, we're talking about arterial or arteries, okay? So this is the blood that's going to your tissues for oxygenation. This is by far the most limb-threatening of all of the type of ulcers that we have. Okay, so what happens is you have atherosclerotic plaque formation that can occur, and it occludes those arteries. All right, so it's pretty prevalent, and it results in limb ischemia. So who's going to get this? So if you look at your patients with smoking is probably the single biggest factor, smoking and tobacco use. The second thing that you should consider is diabetes. So think about diabetes and arterial disease as cousins, because diabetes will accelerate atherosclerotic plaque formation by somewhere between 35 and 45%. So that means you will build plaque faster in your arteries if you have diabetes. Okay? So it increases your chance of bleed by 2.2 to 4% increase, fold increase. So if you have advanced age, the older we get, obviously the more at risk we are. And it will start with intermittent claudication. So do y'all know what that is? Anybody? Intermittent claudication is pain with exercise. So they're going to tell you when they start having oxygen demands, greater oxygen demands that have to go to those muscles, they will start to tell you that they hurt. They can't walk for very long distances, things like that. Ironically enough, one of the things that you can do if your patient has intermittent claudication is you can put them on a progressive walking program to start improving their blood flow and build lateral circulation. So what that means is you have them walk to the point of pain, rest, and walk to the point of pain, rest, walk to the point of pain, rest. And their endurance should be improving. As you build lateral circulation, it will help their circulatory status. Does that make sense? So early on, progressive walking is very helpful. Unfortunately for me, by the time these patients come to me and we get identified, they are long past intermittent claudication, and we have ulcers and rest pain, night pain that's pretty significant. So also patients with hypertension are at risk, patients with vascular procedures can be at risk too. And that makes sense, just think about it. If you have a crushing injury or you have some sort of vascular issue, you know, you're gonna be at greater risk for having damaged and altered flow. Periodontal disease, and then ethnicity, this is higher in African American individuals. And then just as an FYI, I will tell you this, anecdotally, this is higher too if you live in the South. Go figure. You can control some of the risk factors. You can control, sedentary factors. You can control smoking. You can control your diabetes. You can't control your gender, because this is a much stronger male gender. So there's these classification scales, and at first it starts with asymptomatic, and then you go all the way to gangrene. So I just want to clear this up really quickly, because this question comes to me a lot, is when we say a person has gangrene, that is not an infectious process, okay? That does not mean you have an infection when you say somebody has gangrene. That is simply an ischemic process. So when you say you have gangrene, that means there is no flow going there, no blood flow, okay? So that's why the tissue is dying. All right, so where are these going to occur? They're going to occur in the toe tips or the web spaces, so between your toes. They're going to occur anywhere you have a trauma that you have absence of perfusion. Mostly they're going to occur on the toes, because that's the most distal area, right? If you think about it, distally, that's where you're going to see them most. So this is what they're usually not going to drain. They have a deep punched out appearance if you can see them, but they're mostly covered with necrotic tissue. Now when you look at the legs, and I'll mention this, because this is very important when you're looking at their perineal skin. It's shiny, it's taut, it's thin, it has no hair growing on it, and there's atrophy of the sub-Q tissue. So I'll show you some pictures of what that looks like. But, I mean, their legs are just like slick and shiny. So, here you go. So here's the first toes. You can see they're absent or diminished of a pulse, they have poor capillary refill, and they have ABI below 0.08. An ABI is an ankle brachial index. And what that means is I check the systolic blood pressure in my brachial artery, and you check it in your ankle via Doppler, and it should be 1, right? I should have the same flow here as I do in my feet. So where I have differences would indicate that there's a difference in flow. And if it's below 8, that's a significant difference. If it's below 5, that is limb-threatening. Okay, does that make sense? So, okay. Alright, you're gonna check pulses, posterior tibial, dorsalis pedis. Capillary refill should be less than 3 seconds, and their skin should be warm to touch. If it's cold or pale, cyanotic, that's a problem. And then you also get pallor on elevation independent rubor. So if you lay your patient down in the bed, you tell them raise your leg up in the air. When you do that, after 45 seconds, if they can tolerate that, it'll get a very pale color. Then you have them sit up and put their foot on the floor. When they do, it'll get this ruddy rush of blood, and it's this ruddy ruby color. You know, like a reddish, brownish brick color. That is a sign of dependent rubor after pallor on elevation. And that means that your patient has likely arterial compromise. Again, shiny taut skin, absent of hair, and they will have thick and yellow toenails. Okay, this is gangrene. That's an absence of perfusion. There is nothing you can do to save this tissue. You can try to have revascularization, but those toes that are black are gone. Okay, so they're going to come off regardless of what happens at this point. So this patient could end up with an amputation of the whole limb, or they could end up with a procedure in which the artery that's blocking the flow is opened up to allow for adequate blood flow. Okay, and so the lady next to it, can you all see how shiny her skin is? You see no hair growing there? That's an arterial wound. That's the dependent rubor. You see the difference in the color of their feet? There's another arterial wound. Notice the shiny skin around it. No hair growing anywhere there. Same thing, this is in those toe tips. You see the thick and yellow toenails. No hair growing across the toes. And you see that it's starting to break down over here between these toes. And they'll just keep breaking down because it's a sign of no blood flow that's declining. And you see, notice how, when you look at capillary refill, notice what the nails look like. See how pale and white they are? I mean, that's not normal. They should be pink. And okay, so this is a patient that this limb is dying. So I wanted to show you guys. Can you all see this is their opposite limb. See the difference in the color? In the toes? And so here's another example. Okay, and so you're looking for those thick yellow toenails. And again, and I will say you guys see hair in this picture. That is not the patient's hair, that is their pet's hair. You see across the top of those toes, and they're scattered. Notice that you have breakdown across multiple areas from lack of flow. Okay, so pain progresses in this way. Remember we talked about intermittent claudication? Then they will develop rest pain. And that means that it's occurring even if they're not active. And then they get nocturnal or positional pain. So when you have nocturnal pain, these are the patients who tell you they cannot sleep at night. Their legs are just killing them all night long. They sleep in recliners or sleep with their legs dangling off the bed because they can't stand for them to be out of a dependent position.